So our next session is on panel discussion. The topic is cochlear implant, and we are having the stalwarts of our country as panelists. So I'd like to just I'm taking some time to bring the chairs on the dais. Please be patient. Verma ji aa jaiye. So the moderator is our popular Verma ji, Kailash Verma. He has recently organized MidtermIcon in a brilliant way at his hospital. It's a live surgical workshop, an excellent surgical feast, academic feast we have experienced. And the panelists are Dr. S.P. Dubey sir. Sir, please come on the dais. He's a person who needs no introduction. Dr. Ravi Ramalingam sir, sir, please come on the stage. He also needs no sort of introduction. Our own N.V.K. Mohan, Dr. N.V.K. Mohan, Dr. M.N. Bhattacharya sir, Lieutenant Colonel Sunil Goyal, my friend Dr. Arindam Das, and Dr. Saumitra Kumar.
Should we start?
Yeah. You can start, yes.
Good afternoon, ladies and gentlemen. First of all, I would like to thank AOI West Bengal for giving me this opportunity to moderate this session with stalwarts of the country. Ravi sir is here, Dubey sir is there. They are well-known person in the field of cochlear implant. And in the audience, many stalwarts are there. Cochlear implant is a boon to society, humankind, given from science. These are our panelists. They need no introduction. Already our friend Debu has introduced them. In 1802, Ludwig Beethoven fell into a deep depression following a nearly complete loss of his remaining hearing, and his physician recommended rest in a village, then now a part of Greater Vienna. Here, this place, he wrote one testament and addressed to his two brothers and meant to be read after his death. In it, he said, "For me, there can be no relaxation in human society, no refined conversations, no mutual confidences. I must live quite alone and make creep into society only as often as sheer necessity demands. Such experiences almost made me despair, and I was on the point of putting an end to my life. The only thing that held me back was my art. Thus I have dragged on this miserable existence." Another quote by the famous Helen Keller in her book, The Story of My Life. She wrote, "I am just as deaf as I am blind. The problems of deafness are deeper and more complex, if not more important, than those of blindness. Deafness is a much worse misfortune, for it means the loss of most virtual stimulus, the sound of voice that brings language, sets thoughts astir, and keeps us in the intellectual company of man. These poignant descriptions convey the feelings of isolation that often accompany deafness." So, just 40 years ago, there was no effective treatments for deafness or severe hearing impairments. The advent of cochlear implant changed that, and today implants are widely regarded as one of the great achievements of modern medicine. It is really a boon from science to mankind to alleviate sufferings of the needy. So, this is a panel discussion where we are going to discuss mostly surgeon-related things, because we don't have any audiologist, speech language pathologist or radiologist. So mostly we'll concentrate on our field, and we'll go in some part of radiology also. So candidacy. The first point is candidacy. The first question I will ask to our stalwart Ravi Ramalingam sir. Sir, candidacy, this implant has started 40 years back, and the horizon is expanding. So what's your take, sir?
I can tell you what we do in our hospital. Ideally, we'd like to do the implant as early as possible. I know that in Australia, when I was there a couple of years ago, most of their children are identified and implanted by the age of 6 months. Although that is maybe a long-term goal for every center, I think practically that is not the situation in our country. So if I can get a patient to have surgery by the time they are 1 year of age, I'm very happy. More likely than not, it is below the age of 2 or 2.5. Although the Tamil Nadu government approves implants for the age of up to 6 years, I think for best results you must have them below the age of 2 or 1.5.
Sir, Dubey sir, your take, sir.
He is absolutely right. Implant, as soon as it done, gives better result. But unfortunately, in our country, patients don't come so early.
Yeah.
But still, if we follow that the child should have an hearing aid after diagnosing the problem that he has got profound hearing loss or moderate to severe hearing loss, as far as the candidacy is concerned, is expanded like anything. Previously, we only implant profound hearing loss patient, but now we are going to implant patients who are even the severe hearing loss, because the main concern is to development of the speech. And the candidacy is also developed for the not only in the children but in the adults also who are not going to benefited by cochlear hearing aid. They are also be implanted, and more people are implanted worldwide unilateral hearing loss also. So as far as candidacy is concerned, the implant scenario has widened and more people are being implanted. There is a discussion between me and Ravi that whether we should implant a patient who is willing, even after advising that your age is, you have passed the 7 years of age, but somebody is coming at 12 years of age. If they say that we are using hearing aid since last 5-6 years and we have certain sound perception, I would like to implant those patients, though sometimes they may not be continuing with the implant. But I have few patients with me in which I have implanted at the age of 18, at the age of 28. They are still using implant and happy.
Sir, most of the government schemes, they are allowing there is some age limit. Some says 11 years, like in our railway it is 11 years. Somewhere it is written 17 years. Mohan sir, what is
the AOIWBCON scheme says 5 years.
5 years.
They don't give it.
So
See,
there is no uniformity. So
see the
But
point.
in post-lingual it is 17 years.
Postlingual,
in
yes.
that-
Postlingual. Postlingual, it's 17 years. But you know, the point is.
in our railway, it is 11 years for prelingual.
11 years for prelingual.
Yes.
That's.
It is taken from CGHS.
No, but this is news to me.
AOIWBCON scheme is 5 years.
This is news to me.
I think the question is how much is that 11-year-old child prelingual with no speech stimulation? How well is the child going to do? That is a question you must be clear with, the child must be clear with, and more often than not they turn out to be non-users.
See, the point is, like Ravi said, I mean, if it's a progressive hearing loss, you can implant a child at 11 even if it's prelingually deaf, but that must be progressive. They must have had decent speech. We have seen a patient of even 23 years old being implanted prelingual deafness, but that was progressive hearing loss. The child had decent speech. She was attending, she was doing post-graduation from Calcutta Presidency University. So, and she had decent speech. So that, I mean, just because it's prelingual, it has to be 5 years. That is probably not the criteria. I think the more important criteria is how much speech have they developed, and yes, and if they have been, progressive hearing loss. If it's profound hearing loss beyond 6, 7, I don't think they're going to get any speech, and they're probably not going to use it. Like Ravi said, they're going to be non-users.
Dr. Manojendra, another question for you regarding postlingual, not prelingual. postlingual, what should be the ideal gap between the complete loss of hearing and surgery?
Good evening.
Hello. Good evening to all my colleagues who are here. First of all, this needs to be understood that cochlear implant, which was thought to be a thing of luxury, is a commodity of extreme necessity. So, and we are happy that because of our colleagues India-wide, they could make our government also understand that it's a commodity of luxury, a commodity of necessity. That's first thing. Number two is postlingual complete hearing loss is, again, I would defer to what your question is. It's progressive. We won't wait till when the thing has gone completely off. So, as Mohan has rightly said, that if we can figure out that the person is having progressive hearing loss, then even before having a complete loss, when he is struggling even with the strongest of the hearing aids, and there are problems with speech discrimination, we will plan for doing implantation at the earliest. At the earliest. There is no fixed definition. The earlier we do, the better it is.
Actually,
there is a time frame for postlingual deafness, sudden deafness. It is not for how early you're going to do it, but at what is the maximum age of deprivation, hearing deprivation that you're going to tolerate, beyond which you will not implant. I think that's the more relevant question, isn't it, Ravi? Yes, and I would probably say beyond 10 years it becomes a bit dodgy. 15 years, I don't think I would implant a patient who's been hearing deprived for more than 15 years.
I've implanted postlingual patients more than 23 years. That's the record I have. Hearing deprivation 23 years, and he did very well.
Wow.
Very well. So I mean, of course you would like to do it as early as possible, and you would do it in the year which was hearing till the last, so the later deprived year. But if that gets delayed, I don't think that's so much of a problem. I've seen patients, more than one patient, do very well in spite of, like I said, 22 years. It was my first postlingual patient, 22 years after he got deaf, and he's fine. He's very, very happy. There's no problem. Children, yes. The problem is that, see, I mean, I shouldn't say this. In my hospital, we've done 3,500 implants till now. In my first 50 patients, 100 patients, no government scheme that time. So I was desperate to get and do more, get the numbers in. So at that time, I would implant just about anybody. A 25-year-old prelingual patient, anybody who says, I have the money and I will afford it, I would do it. Then, as time goes on, you've seen the results, common sense prevails, and then you become choosy. So now, normally, if anybody comes to my hospital past 6, I am not pushing them for surgery. In fact, I am dissuading them from surgery. Above the age of 10 or 12, I will say, no, I will not do surgery. I have the luxury because I've gone past those numbers, and the numbers are meaningless to me anymore. For me, it's more important as to what happens 5 years later, 10 years later. All these prelingual patients, he's lucky. I've got a few prelinguals still using the machine, but no, it's not worth it. Not worth it.
Actually, I've got very limited experience of this postlingual adults. The maximum age of this deprivation and surgery is around 40 years. One lady, she got job in handicap category, and somehow somebody, it was not handicap category, some category, something there. So around 30 years gap, 30 to 40 years gap was there, and I didn't get a good result. But around 17 or 18 years age, this deprivation, I got good result. On young girl, around 25 or 26, I got good result. But that old lady, she was around 50 plus when I implanted, but I didn't get a good result.
But I think speech discrimination score is the very major criteria by which you can decide whether you have to implant these patients or not. And one more thing, if you have implanted child 1 year, up to how much time you can implant the second year if they come to you? There are some senior people who says that it is to be done better within 8 years of age. Some say that up to 15 years of age you can implant, but it is better to give them hearing aid on the other side, so that you try to always persuade them. You can, if you want to implant your second year, you get implanted in within 5 years of age to have a very good result. So they do well.
As Dr. Dubey has said rightly, in adults particularly and postlingual also, if we were asking for a single most important point, that is speech discrimination. That's the most important thing, rather than what's the hearing loss and how much the hearing loss is. And regarding the time frame, the latency period, so again, it's something with days coming we can, but we usually, these are one of, 25 years or 40 years, 45 years are one of things. But usually the earlier the better, isn't it?
Earlier is
Exactly.
the better, yes.
See, I mean, these are outliers. We should ideally call these candidates outliers who have done well despite, being implanted so late in the day, isn't it? I mean, you can't always expect good results.
What I meant to say is that if a patient comes to you 20 years later with good speech, I would ask
You'd still, yeah. So, yeah. That's the whole point. But with guarded prognosis, with the guarded prognosis that they might not. They might not get, the desired
Dr. Saumitra wants to say something.
Adding to what Dr. Dubey said, I think he remembers that he came to our center and he operated one child who was nearing 6 years of age, and she got an implant on one side and she had a hearing aid on the other. And later on we found out she started developing a speech, but later on found out her implant was not working. She was actually hearing through the hearing aid on the other ear. So that's a very important point sir said, and I could relate with our center experience, and sir had operated on it.
Dr. Goyal, please have your words.
I would like to just summarize what the whole discussion has been going on. So in armed forces, we have divided into three categories: the prelingual, the perilingual, and the postlingual. So the confusion was in the perilingual part. So prelingual in our armed forces we are doing before 5 years of age. And recently we have a change in policy. Earlier we were doing only unilateral implantation. Now for all prelingual deafness where the ear is available for implantation, suitable for implantation, we are doing bilateral, simultaneous, and those who have undergone earlier unilateral, if that implantation has been done within the last 1 to 2 years, then we are offering this, because most of the studies suggest that the sequential implantation gives better outcomes if they are done within 1 to 2 years. Regarding perilingual deafness, the age limit we have kept between 5 to 15 years. Of course, these children are progressive hearing loss, or in later part of their age they have developed hearing loss, maybe because of meningitis or some other trauma or any other factors. So in those cases, if the child has some form of speech developed, we go ahead with the implantation, but in those cases we are still with unilateral implantation. And postlingual, there is no age limit. Of course, the auditory deprivation part is there. If it is too prolonged, then maybe the outcomes may not be so good, especially with the ganglion cells going down, and there is no form of investigation by which we can determine that. So we have to proper counsel the patient. If they insist that I want to go ahead with the implantation, they should be counseled that if the deprivation is too long, maybe the outcomes may not be so good.
For Dr. Arindam, I have changed the question. Regarding this candidacy, one absolute contraindication was cochlear nerve aplasia.
Yes.
But recently, the view is getting conflict. So what's your take?
So look, in our institute, what we do from majority of the patients from the government scheme like ADIP, so in that case, the most of the patients should be normal cochlear nerve. Okay, so in that regard, so we have very little experience on the cochlear nerve aplasia doing cochlear implantation. But according to literature, recently the cochlear nerve aplasia patients also the cochlear implantation can be done in some situations. Okay, and if there is auditory stimulation, because this aplasia is a radiological diagnosis. So when we have a MRI and that the nerve is thickness is very less, is a hypoplastic, or if you cannot recognize the nerve. But somehow, if the audiologist is confident and there is some sound stimulus that can be passed through any part of this nerve or the very thin nerve, then there will be some chance that can be taken for the patients. And this is the situations where we can do in the
Is there any
also.
role of any electrophysiological test in this type of cases?
Yes, we can use frequency specific beta and also the ASSR.
Dr. Manojendra, please. Sir, you are the master, please. Enlighten us.
So like I said, I will not do implants for children with cochlear nerve aplasia. Full stop. No. I've done a few with hypoplastic cochlears. The results are usually not good. Let's be clear. You want to do, you do. You don't want to do, don't do. But don't tell yourself this child will be okay. They are not going to be okay. So, it's the same spectrum. Patients who've got developmental problems, who've got hyperactivity, who've got autism, who've got multiple developmental problems, who've got a thin nerve, they are not going to do well. Now, if you convince yourself and convince everybody, no, we will do the implant for whatever benefit, that's you. But in a government scheme, the problem is the patient is usually a poor patient. The patient is somebody who's not educated. And if you're going to give a wonderful result, yes. But if you're going to give him a so-so result and try to convince him otherwise, again, non-user, eventually
Yes,
not
sir.
soon enough.
Yes, sir. That is
You
true.
cannot be clear who you're going to operate on. Don't really push to do everything you don't want, because you're stuck with the patient. You are stuck with the patient, not for anything else. I see the patients who I've operated on 20 years ago, they will still come to me. If they are happy, it's wonderful. If they are unhappy, you're stuck with the patient. So kind of keep that in mind. They won't do well.
So I'm just going to take what Ravi said forward. See, a very important part of the counseling process is this setting of expectations. When you are deciding on the candidacy, setting the expectations of the patient, of the family, is a very, very vital part of it. And like Ravi said, in a poor patient, if you're doing it because the government will give only the implant, all the accessories, if there are any problems with the accessories, they'll have to buy themselves. So you're actually burdening that patient by doing these kind of patients with in the gray area, right? On the other hand, if it's an educated patient and they have proper expectations, they understand completely well, then it makes sense. Because they know that they're going to get limited benefit and they are ready for that, and they can actually afford whatever the extra expenses that come out of it, right?
I think Ravi is the person who has done in his center brainstem implant also, which is even 3 times costlier than the cochlear implant. And results are very, patient can only have sound perception, but still people are doing brainstem implant. Why? Because they should get a sound perception only. So even if a little hope is there, I am of the thinking, because ultimately there is no answer. He said rightly, Mohan, that you counsel the patient, tell everything to the patient, that this might be the result. If they are agree, because this is the only hope, I think we should go it, because we have seen results, like he said, sometimes radiologist reports were not good. We have not expected a good result, but good result was there. There is the only hope. If patient is willing to pay, because national program or the state government program will not issue this patient any implant, because they are not fitting into the proper criteria. But if a patient coming privately, they have got ample of money, they are ready to understand, definitely we have to give them chance, because this is the only chance which they have to listen. Otherwise, they will remain in the world of...
Actually, it all depends on social setup of the place, because our society, we are poor people, fund crunch situation is there, and the research paper, these research papers are coming from affluent countries, so they can do anything.
Sir, I'd like to add one point.
No, what is, I'll tell you my story of brainstem implant. We did 4. One patient had nothing. We had a surgeon from France, a very respected, renowned surgeon, Dr. Jacques Magnon, who was a good friend, who came here, who helped us start. One patient had nothing. One patient had vibration of his chest and shoulder muscles when they stimulated the implant, so we had to shut it down. The remaining two had something, but what does something really mean? What does sound perception actually mean? Patient has sound perception. What does that mean? You hear a telephone bell or a calling bell there? What difference does it make to the patient? And you spend 17 lakhs of the government's money, and you're telling yourself, oh, he's got sound perception. That is not enough. That's not enough. You have to be clear as to.
Sir, that is what I am telling you, that 17 lakhs we have done in brainstem implant. So cochlear implant is costing only 5 to 6 lakh of rupees. And if sound perception means a lot, if you are in the house, your child is there, if you are ringing a bell, if he opens up a door, if he's roaming on a bike, I have seen my own patient, they have got lot of mirror over the scooter. But now after implantation, if somebody honks, he will get aside. You are walking on the railway track in a village. If implant, even sound perception is a very important thing. What I will say that Dr. Ravi, you have implanted brainstem, lot of money was gone there. In cochlear implant, you have a less money. If you have a cochlear nerve, even thin nerve, that chance should be given after proper counseling to the patient, whether hearing will come or not. The chance should be given, because you see neuroplasticity, brain is a very miraculous thing. One of the lecture I was listening when I went to the San Francisco in unilateral cochlear implant is, they are doing a lot of unilateral cochlear implant. Previously it was thought that unilateral cochlear implant should not be done. But now they were telling that there is a conflict between the acoustic noise and the natural sound. But brain is such a smart thing. They have done unilateral cochlear implant and they are having good results. You never know that how brain is going to react. So in my opinion, I think if somebody is ready to spend the money.
Let the Goyal give some opinion.
In our setup, of course, cochlear nerve aplasia is absolute contraindication for cochlear implantation. But just from a theoretical perspective, what is cochlear aplasia today may be a cochlear hypoplasia tomorrow. It's just the imaging modality which is available, which is making it delayed. Maybe we are not seeing it today, but with 5 Tesla MRI or something else comes up, we may be able to see them. And right now, to find out whether this patient are going to benefit or not is very difficult. We don't have any investigation with us, but some people do suggest that transtympanic promontory stimulation can give us some idea, and maybe central evoked potentials if something we get from there. Then patient counseling with proper counseling, like all the panelists have suggested, and if the patient is willing to pay, and I think it's...
You see, Ravi is a very influential person. He is in the committee and people are in the committee. What people are doing now? People are doing, when I went to Aliyawar Jung, they were insisting that the age should be reduced from 5 to 2. I objected. Because you see in our country, people are deaf, they are reporting late. Even we have implanted those patients, thousands of patients he has implanted. Ultimately, they are listening out of them, something is there. In our country, you cannot expect ideal condition. If government program, in all the corporate people who are giving implant, they are restricting age should be 2. All the ideal condition, because we want value of our money. So if you do like this, government works on charity. Government's for poor people. So we cannot reduce the age like from 5 to 2 like in Western world or Australia. In our country, I think program must run like this, and people may not be getting full benefit, but if even they are getting some benefit or partial benefit, they should be provided with the implant.
Yes, correctly said Dr. Dubey sir. 1 second I want to add. In majority of these programs in the government ADIP scheme, childs are come at the very later age, in the 4 years, 5 years, and we have to do this under the criteria. So we do this cochlear implant on these patients. After some year, 1 or 2 years, their parents are very happy. Actually, we regularly talk with them. They come for our their mapping or everything. So they are very happy. The child may not speak very fluently because the age has been gone, but this reception of sound, and they can identify, and the patients are very happy. Their father and mothers are really happy, and this is also a very good thing to get. from any type of implantation program.
Yes, and there is a subtle change in the behavior of the children. First they were very hyperactive and they were not listening to anything, but now they grow calm, and that's a very good thing for the parents.
There is a need to strengthen the AVT therapy people. And there is a need to motivate the parents for the AVT therapy. The most important thing which we are lacking, that the parents are not bringing their patients for longer period of time for the AVT therapy. I think if this sector is strengthened, definitely we are going to get more and more good results.
On a lighter note, I want to say Dubey sir is also very influential. That's why the age has not been changed. This is one paper published in some journal. It's an American paper, and the author is some Dr. Rajan. Here, regarding the expansion of the candidacy. So, what other things we can include for implantation? So, this is some study. They have included Meniere's disease, disease with vestibular schwannoma, otosclerosis. Dr. Goyal, please.
Whenever I'm looking towards conducting implantation, the basic thing which I need is intact cochlear nerve. The inner anatomy should be available, and there should be a luminal patency where I can put an electrode. And if the patient has a severe to profound hearing loss, and then on all these conditions, maybe we can go ahead with implantation. And I think it's part of the expanding indication for cochlear implantation.
Dr. Manoj?
It's the same. Anatomically, if it is viable, and if physiologically we think of that we can give a good result, and again, good result is very relative. I go with what Dr. Dubey has said, that nothing and something, it makes a hell lot of a difference in our sensory input. So if we can give, then definitely why not?
Sir, in case of otosclerosis, at what stage we should consider for implantation?
Again, if it's a case of cochlear otosclerosis and the patient having difficulty in discrimination, then we can start at least counseling the patient that you might need, because from counseling a patient to taking him to the table, there is a hell lot of a thing. I think here, I mean, in otosclerosis, if we have cochlear otosclerosis, that is, there is sensory neural hearing loss, there is radiological evidence, and if the speech discrimination is falling, if it's beyond, say below 50, that's when, I mean, whatever be the air conduction, I mean, the conductive component, I think they are candidates for implantation, because sooner or later they're going to have luminal patency issues. So, and once the lumen is lost, we won't be able to do much for them. So I think that is the more important criteria, considering the speech discrimination.
Before the lumen gets closed.
Absolutely.
Yes. Then the next thing is this threshold. Hearing threshold is lowering down for implantation day by day. Initially it was 90, then came to 70. Right now it has come down. So, sir, please say something.
No, I think in our hospital, 70 is still the level we would really seriously consider an implant. Below 70, 60, we would probably push for a hearing aid trial before we take a call. Adults is easy. If they're not happy with the hearing aid, then you would talk about an implant. Whether it's 60, it could be a sloping ski slope kind of audiometry with normal hearing at 250, 500 and nothing after. That would still be a candidate for a cochlear implant for me. So it depends. For an adult, if the hearing aid is helping or not helping, that's more important, with discrimination, of course. For a child, normally I would still stick at 70. Anything better than 70 will have a proper hearing aid trial.
Dr. Saumitra?
I would like to tell you a small story about this expanding horizon. It's very interesting. One of our, I work at a government hospital. There is no scope for cochlear implantation there. One of our nurses, she came to us with her son. He's 30 years old. He has a unilateral deafness, and she was very persistent of getting operated. So we said, see, there is a thing called cochlear implant, but we can't do it on a unilateral. I mean, nobody can do it on a unilateral. We suggested the names of Dr. Dubey, Dr. Ramalingam, and Professor Rai Chaudhary also. We said that you can go to them, but I don't think they will operate on a unilateral thing. So she told me, say, when my son was a child, 5 years old, I had gone to some ENT surgeon. They said there is no such operation in this world. Now there is one operation. Probably 10 years later, we will have some operation for this unilateral thing. So this is what the expanding horizons is all about.
So the conclusion is the age has come down. People have started implanting at the age of 9 months in prelingual children. Then this threshold has come down. This speech discrimination score has come down. Many more diseases has been included, and in future many more will be included. It all depends on our economic setup of the country, social setup, what we want, what we can provide. All these facts have to be considered. Now we will move to, there are some absolute contraindications, that is labyrinthine aplasia, cochlear aplasia, complete cochlear ossification. This cochlear aplasia again a controversy, but still will go in favor of cochlear aplasia as a contraindication. रेडियोलॉजी सर आपको को अगर बोला जाए कि आपको एक ही करना है, सीटी स्कैन या एमआरआई, तो आप क्या प्रेफर करेंगे?
नहीं, हम तो दोनों कराते हैं साहब।
नहीं कराते हैं सर, दैट वी ऑल डू।
बेसिकली
एक से मेरा काम नहीं चलेगा।
Okay, at least one thing, post-lingual adult, I want a CT scan. Because you know the nerve is intact and he's speaking well at least. So, एक तो करना है, so you can do CT scan for an adult.
Yes, sir.
But in children we tend to do both.
Mohan sir?
Insist on both. Like I said, push comes to shove, like postlingual, you can do with CT, but in children you need both. दोनों ही करवाना है. मतलब you're looking at different things.
मेरे यहाँ एमआरआई के साथ सीटी फ्री किया जाता है।
सर आप ही के यहाँ भेजेंगे सारे पेशेंट। डॉक्टर अरिंदम?
Yes, this is not at all an option. So we have to do CT and MRI both, because they both have some roles during this planning of the cochlear implantation. The CT gives you the bony details and the cochlear anatomy, facial nerve, facial recess, everything, and the mastoid pneumatization, etc. But the MRI, on the other hand, they give the membranous cochlea, the nerve thickness, everything. So both are important. So there should not be any options. And what Ravi has said, for adult, we know the speech has been generated, so definitely there will be a nerve. So that may be, yeah, but definitely two things should be done for every cases.
Sir, Goyal sir.
Like the panelists have said, I would like to have both of them, but if it's an MCQ question, I would say an MRI. Because that will tell me the cochlear nerve is present, the cochlear lumen is present. Even if there is some early ossificans change, I can make out, suppose the patient is post-meningitis. So an MRI would be a better option for an MCQ, but otherwise I prefer.
Dr. Mohan, please.
What I was trying to say is, in today's day and age, with this thing of medical legal implications, I think we should insist on both. No compromise here. No compromise here.
Dr. Mohan, please tell us what all things we have to look for in CT scan, HRCT temporal bone.
See, CT scan, I mean,
how should we advise to the radiologist?
See, what we like to look at is, first of all, what is the cochlear, structure like? I mean, is it a completely formed cochlea? All three, 2.5 turns. How's the vestibule? Look at the whether vestibular aqueduct. Look at that, and also within the cochlea, you need to you want to see the interscala septa. You want to see the modulus, because the cochlear malformations. These are important things that will define whether whether you have a modulus or not, whether you have a normal sized cochlea or not. All of these are important in classifying the malformations. And also the other thing that you need to look at is whether you have a communication with the internal acoustic meatus. So, some malformations like, say in IP1 or IP3, there's obviously no modulus, so you will have a, communication with this thing, and you'll have a gusher, right? There are certain other situations where you can have a slight erosion, say a fracture. You can have an erosion, and these are the patients where you should be expecting a CSF leak. So these are the vital things that you need to look at, and also you also look at the so pneumatization, jugular bulb. How is it placed? If it's the dura, if it's low lying or sigmoid. So you look at all those anatomy for the.
Dr. Manoj, please.
This radiology gives us two information. One is whether it is viable or not, how the anatomy is, and how smooth would be your road for driving, for the surgery. So what Mohan has said is absolutely correct, which gives us an idea what is going on inside. But apart from that, few more things. Number one is your jugular bulb. Axial cut gives a beautiful picture of the jugular bulb if it is protruding inside in our path of viewing and putting the electrodes. So that is very important. So that jugular bulb needs to be seen, and if it is there, it's not a contraindication, but you are mentally prepared that what I am going to do while I am doing the surgery. And then it becomes a cakewalk. Otherwise, if it comes all of a sudden in front of you, then you start thinking of, or inadvertently, if the drill head strikes it, then you have to spend a bit of extra time in it. That's number one. And number two is the space you get in between the facial and the chorda tympani. So these are small bits which you can get the information before putting the knife on the skin. So this is from CT scan. You asked about the CT scan, isn't it? Okay.
There's one other thing that I'd like to say. What I am trying to do with my radiologist, because we are both learning. Both of us are learning. I mean, we have a paucity of radiologists who understand CI radiology, at least in our state, and we are trying to learn both. So now I'm also looking at the length of the basal turn and the mid-modular height as well. And also I'm trying to calculate the A value, because that will give me the cochlear duct length, the A value. And if your basal turn is less than 7.5 millimeters, or if the mid-axillar modular height is less than 3.42, I mean both of these together, then it becomes cochlear hypoplasia. So that directly impacts your outcome. So you have to counsel the patients accordingly. So I'm starting to look at those as well now.
And we have to order separate electrode also.
Yes.
Smaller
Yes, of course.
Yeah. Dr. Saumitra.
Is the problem of this panel is this is like a visual analog scale, but this is the 0 and that is the highest. I'll tell you why. I'll tell you why. Because of the experience in cochlear implants. Because at that spectrum are two people who are very experienced in cochlear implants, so they are dealing with something called CT, MRI, and they don't have to speak to the radiologist about what they want to see. Yes. Because the radiologists already know that this is a cochlear implant patient. And in my case, I work in a government hospital where CT scan and MRI both are done free. Free means it is not free. The government pays for it, and the government pays very poorly for it. I think 500 for a MRI and 350 for a CT scan. So they provide only that type of pictures. Yes. So it happened that we got a CT and MRI and we got actually no information.
Actually, this is the practical problem.
Yes, that's what I am telling you. So that is what we faced. So then we had to ask Professor Chaudhary sir where to send for this CT scan, and then he suggested some place, and so you have to send to the right person for the right CT scan. We don't have that choice that doing MRI and CT both.
Dr. Arindam is the right person. Sir has made a, sir is gone.
Sir had given a presentation today morning. Actually, this is the same situation.
SSGM is one of the pioneer ENT center in the country.
Yes, sir.
It's an institute, and they have got tremendous facility there.
Yes.
So
yes, we have a tremendous facility in terms of microscope, nerve stimulator, everything we have. But the same situation is over there also for the CT and MRI. Oh. They are absolutely free of cost to the patient, but we have fixed the situation by doing a simple thing. Every time we write a CT scan or MRI, we write a single word, please provide a DICOM image on the CD.
Yes.
And in every time we do software, DICOM software, either is a Horos or Osiris, whatever. And before surgery, we have to see every CT for the patients. And from this panelist, all the sirs have already described the axial cut, coronal cut. But before going for surgery, we also give some reconstructed cut, like Stenver's view and the Possel's plane. But this gives a very good idea of the cochlea, how the cochlear turns are, and the facial nerve anatomy along with the facial recess. So these are also very important. And along with the 3D reconstruction, when we have the DICOM, we can have a 3D reconstruction, and this is like a virtual endoscopy. Like you are putting endoscope inside your ear, and you can visualize the round window. So if the surgeon is versed with the round window anatomy, at least the bony anatomy, before going for the surgery, so there will be less chance to get surprised during the surgery, this is a very small round window niche area, or is a very difficult to find out. So you can have a very good 3D images from the CT scan. So how can we have fixed this problem in the government setup?
Ravi sir, you have got vast experience in this. Yes, sir. So please enlighten us.
Now I'll answer the question 5 and 6, and I'll tell you a story. So what happened about 3 years ago, we invested and bought a cone beam CT in our hospital.
That was my next question.
Yeah, so the cone beam CT, we bought it. I mean, we were the first, I think, among the first ENT hospitals to buy it. So now we have a machine in the hospital. It's next to my room. And literally any patient who walks into the hospital, comes for a sinus problem or comes for a ear problem, they do a cone beam CT. Now it's the same image grabbing for the nose or the ear or both. So literally for any patient who comes into the hospital, we've got DICOM images of that particular patient. And now if you're doing, we do a lot of CBCTs, and that number increases over the years. So in 3 years, we've got thousands of images stored in that machine. So implants was one side. I wanted to do that for stapes, and I'll give you that example. So I caught one of my PGs because I could not read it, and that's the truth. Even today, I cannot read the stapes footplate properly because I haven't bothered to look at it so many times. But I have a PG, and I said, look, your thesis is on stapes surgery, and you have to tell me before every operation what is your finding on the CT scan, and I will corroborate that during the operation. That way you improve and I have information before. And very quickly, she, first year PG, primary DNB, no experience in ENT. Within a matter of 1 month, 2 months, she was excellent. 90% of the time she will tell you, thick foot plate, the facial nerve is overhanging a little bit, narrow niche, incus is eroded, whatever. The findings were perfect.
So tell me when she passes, I will go to.
So what I'm saying is the same thing happened to implants. So the anatomy of the nose is easy. I'm sure all of us are experts in CT PNS. How many of us are experts in CT temporal bones? It takes more effort. So get the DICOM. What you said was perfectly correct. Get the DICOM. You're all chiefs now, you're all seniors now. Get your junior most PG and make that Bakara learn. It's good for him. And you get the information as well. And you will learn through him. So that's how we do it. That's how we do it. And that's how we've gotten better. And the images of thousands of patients are in my system. So anybody who comes for a fellowship, and there are some people who are coming, I will tell them, you have free time, go look at 100 images and learn to read the scan properly. That's the only way you get better. Information is there. And now if I do a post-operative, and that's what the picture that you put up, what do you do? No Stenvers, no modified Stenvers, all that is gone. I would do a CBCT for a post-op, and I will tell you, is the implant completely in the scala tympani? Is the basilar membrane deformed in any way? Is there a damage? What is the depth of insertion? All that information is there, perfect. I have pictures, and perfect pictures are there.
Sir, what is the cost of this machine? I think 30-40 lakhs or more.
Okay, official price is 53 lakhs today, quoted price. I was the first one, so I got some beginner advantage. So it came down. But today's quoted price is
50 something.
52, 53 lakhs.
So in
But it's a great investment. Believe me, in private, it's a great investment.
Yes, sir. Adding on to sir's point, like in our department we don't have, but in some of our armed forces we also have a dental unit with that, and many of the dental centers have this cone beam CT. So in some situations, especially where we want to get post-op imaging, we send the patients to dental center and we get the cone beam CT from there also.
Remember, you can't do it for somebody less than 5 years of age because patients should not move the head for about 30 seconds.
Yes, sir. We have modified that by holding the patient.
Holding the patient, yeah. We've done that too.
And I think in dental machine and our ENT machine, some difference of gantry is also there. I think we have a bigger gantry.
I think it is same. It is same. Yes. Yeah. So these are structures we have to
And
look for in the
radiation is
MRI.
less. Radiation is.
So I will not go in much detail, because I have already taken much time in candidacy. This is MRI findings. Everybody knows who is involved in this implantation. These all pictures has been provided by our Dr. Mohan. He is a brilliant radiologist vis-a-vis cochlear implant. So this is the formula with which we arrive at cochlear duct length. So my next question was this one, CBCT, already discussed. Then a big controversy, surgical methods. Dubey sir,
No controversy. I think people have accepted this, and everybody has got its own way to bell the cat. And if you are getting good results, there is no controversy. You can see the posterior tympanotomy is the gold standard, because the cochlear implant surgery started with it. People have some difficulties, so they sought for the other method, and ultimately by doing a lot of experiment, they ultimately stick to the Variac technique or transcanal technique, in which also people have done more than 10,000 surgeries in our country. God knows whether in Dr. Kira Triffon's place also, or in other European countries, who is doing this. So with the time proven, both the techniques are time proven, both send implant into the cochlea, both the implanted childs are listening. I think the way you learn the things and way you consistently deliver the result, I always quote Dr. Vijendra's quote that by which method you are getting good results, try to do it again and again, so that you can do that method on thalamic level, and you should not put much effort. I have learned posterior tympanotomy in my initial career with Dr. Ravi Ramalingam only, and if you see him operating posterior tympanotomy, it seems like it's a very easy surgery. That subsequently I exposed to the transcanal technique by Dr. Hans, and I find that also very easy and very easy to teach others. And I am proud to say that there are 4 or 5 people who are more than 60 who has started doing implant, and they are doing implant confidently with transcanal technique. I modified on objections of my posterior tympanotomy colleague that it's a blind technique. I make a new technique which is known as Bhopal technique.
It is playing, sir.
And even Amritsar, people have done more than 100 cases with Bhopal technique. They are also getting good results. So, I mean, surgical technique is something by which if you are happy and giving good results, follow it. So there is no controversy at all.
Yes,
Well
absolutely,
taken,
sir.
Dr. Arindam,
Yes, sir.
this technique which we are playing is Bhopal
It's a
technique.
Bhopal technique.
Yeah.
This is a very
Then Dr.
Yes.
Arindam will enlighten
yes.
us. Please tell us.
Yes, actually, this technique is surgeon's perception. Which surgeon is doing the technique, that's his own choice. Now the endoscope is come into the field of various types of ear surgeries, nasal surgeries, wherever you can put the endoscope. But the thing is, there is 2 types of endoscopic implantations. So one is exclusively endoscopic, that has been already done worldwide. And the second is endoscopy assisted cochlear implantation. So what we are doing now, in some of the cases where there is a very difficult round window situations, because it is a very comparative thing, when the round window is not properly visible, and you have some false membrane over it, then we can use the endoscope, because this is already present in our OT. In our scenario, we use 1.9 and 2.7 millimeter scope to look into the middle ear space, and we got some really beautiful glimpse of the round niche area, diagnosing the false membrane and everything. We can diagnose the high jugular bulb, the fused teeth, the whole the round niche area, and even in difficult situation, we can implant or insert the electrode in the same way like a microscopic implantation. So we can insert into the scalar tympani, and we have done the post-operative CTs on the patients, and there is nothing exceptional like from the microscopic one. So in the proper position in the scalar tympani, there is no scalar drifting or anything has been damaged post-operatively, and the NRT was very good in the patients. So this is something in a trouble situation where there is you cannot find directly into the middle ear by the microscope. The endoscope can be a helpful tool you can use. So there is no controversy, there is no tussle between the microscope and the endoscope. This is basically a tool, and you are the best judge. Wherever you want to do endoscopy, you can put it. Wherever you feel this is a one you can deal with microscope, this is a microscopy. So this is our experience, what we are doing now.
Goyal sir, your take?
So, there is exactly no controversy, but in the words, I was trained under Professor Mohan Kameswaram, and in his words, he used to say for most of the scenarios that is the toys with the surgeon's choice which toy he wants to use. So there is no controversy regarding it.
I mean, absolutely, like everyone said. See, one thing I maintain is, as a surgeon, we cannot be dogmatic. The day we become dogmatic as surgeons, I think we stop growing. So, I mean, see, if it's been working for so many people across the globe, then I can't just write off various as a blind technique. Even if it's blind, it's giving good results. So why should I discredit it? In fact, I'll say something. I mean, I've been doing implants for what, around 12 years now, 12, 13 years now. And the last case that I did, I had a really difficult time, visualizing the round window niche. And I thought, yeah, maybe it's time for me to learn the varia as well. Maybe it's time for me to learn the varia as well. Why shouldn't I not increase my armamentarium? If I run into a problem, if there's a technique that can help me better, I'll be in a better position to decide whether I want to do a posterior tympanotomy or whether I want to go varia. So I don't see a controversy. And like Arindam said, if I have the endoscope, a thin endoscope, 1.9, I mean the thinnest I had, we have is 2.7. But if you have one and if it helps you, why not? Why not? Ultimately, it's getting the job done.
Yes.
That is important.
You have nothing to do. Just during your surgery, regular surgery, we will
It is at
just
your convenience. You are used to with anything, you can use it.
You can use it.
If I
just
come
try to look
good
at
result.
how
That
does
is
it look
the-
like
that
the
should be the
middle
idea.
layer.
If I'm using it in Mastad, why can't I use it here?
So finally, I ask our master to summarize it.
No, I mean, I agree with what's been said. I only do the posterior tympanotomy, that's for the record, but I have nothing against a different technique or modification of a technique. What works well for you is fine. But me personally, I mean, I'm very slow to adapt and adopt a new procedure. I've done something for many years, and I don't see any reason to change, not in cochlear implantation. So I continue to do the posterior tympanotomy. But I mean, everything is fine. I mean, if it works well for you, wonderful. I mean, there's no reason why you should only stick with one technique.
Yes, sir. So to conclude, there should be no controversy regarding the procedure, the approach. This is at the convenience of the surgeon, and the idea should be to have a good result. I think this is the last session, so we can extend a little bit, madam, if you permit. No, actually we started late. No? We started late. 10-15 minutes, madam. Okay. So, posterior tympanotomy, varia technique, subtotal petrosectomy. This is the one technique which we saw yesterday. Dr. Satish Jain. Actually, that surgery when he was doing, I was there in Karnal. So, it is a very helpful technique in difficult situations.
I think
and some special situations.
when I went to Italy, Professor Mario Sana, and I think Neuralink company has organized that trip. And in that trip, they have done 12 cases, adult cochlear implant, all patients of chronic suppurative otitis media. In all those cases, they have done subtotal petrexectomy with the cul-de-sac closure and implantation. So definitely, this is the method we should learn. And because if some complications are there, ultimately, there is a last resort which we have to find. One more thing I want to just add, that apart from the technique, for new cochlear implant surgeon, they have to learn to protect the flaps, how they cover the implant. That is very important. Because I have seen Dr. Ravi is taking very beautiful extra flap to cover the electrode which is emerging from the body. I have seen Dr. Hans, he is also making one Hans flap. Because in all these, both the techniques, the flap handling is very important, because ultimately it is going to give you a result. Because if something goes wrong, that it gives you a lot of pain.
Dr. Manoj, regarding surgery, you want to add something?
No, it's what he has said is very clear that in some special cases, we need to go for a petrosectomy before putting in the implant, particularly in otitis media or cholesteatoma cases or extended implications of the surgery.
So I should skip this video.
I think a comment about subtotal petrosectomy and cochlear implantation. Now, for those of you who've done subtotal petrosectomy, not necessarily for cochlear implantation, you must remember if you're doing it for a cholesteatoma, there is definite chance of leaving behind squamous epithelium inside the cavity. Even if there is no cholesteatoma and you're trying to do a blind sac closure, when you remove the skin of the canal or when you try to close off the external canal, you could leave some epithelium below that closure. So just because you've done a subtotal petrosectomy, it doesn't mean that there is going to be no epithelium inside. Now, the conventional teaching is that you would do subtotal petrosectomy, wait for 6 months for the whole thing to settle down, and then go in for the second stage, at which time you do the cochlear implantation. The advantage of that second stage surgery is that, one, you can image that patient. You could do before surgery an MRI with diffusion weighting, so you know if there is a chance that there is epithelium inside leftover recurrent residual squamous epithelium. It's a good thing to wait, watch and do a scan to see if any epithelium is there. And then nothing is there, you open up, you're seeing the whole thing, and then you put the implant inside. That is the right way to do it. The shortcut is, no, I'm the expert, I will do everything at one go. I've done that. But remember that once you put the implant inside, you can't image that patient anymore. You can't do an MRI easily. Even if you put an MRI compatible implant, that whole area is going to be black, so you can't see anything. So you lose that investigation if you do it in one stage. So be careful of that when doing subtotal petrosectomy.
Sir, we are doing implant surgery. Slowly, experience is coming to us. We are facing some problems, new problems. So, what are your tips to prevent those small problems? Some tips, especially for for newcomers, those who aspire to become a cochlear implant surgeon. What should be tips?
For people doing their first implants, it's good to have a mentor. Someone who's going to be there, who will let you operate and be there for your mistakes, because you will make mistakes. Choose your patients carefully. Choose your patients who are going to be star patients and not the borderline patients who might or might not do well. So your first few patients are the ones that you will show off to other patients in the next few years. So see, look, I did this operation, look, the results are so good. That's what you need. So you need star patients in the beginning. Have the mentor who will help you through difficulties, and the first patients should have a normal cochlea. As time goes on, then you start seeing more and more difficult cases. I tend to do more and more of my implants through the round window. I don't do the cochleostomy anymore. But remember, some implants do better with the cochleostomy, some implants do better with a round window insertion. So be mindful of that. The advantage of putting it through the round window is that you are going to be in the scala tympani. Whereas if you do a cochleostomy and do it in the wrong place, you may end up in the scala vestibuli. Do lots of temporal bone dissection.
Dubey sir, wisdom, advice or wisdom from your end?
Absolutely rightly said. Mentor should be there, and without mentor, you cannot venture by seeing videos, because implant is costly, surgery is revengeful, and selection of implant is very important. Few electrodes are very delicate, but few electrodes are sturdy. Your mentor will tell which electrode you have to use. Even if you handle little roughly also, they will forgive you. But few electrodes are so revengeful, even your one wrong movement will spoil the electrode. So selection of the electrode in an initial phase is very important. Number two, post-operative care is very important. Do all dressings by yourself. See everything. If there is something went wrong, immediately inform your mentor and take care immediately. I will give you an example. The magnet was very tight, patient was wearing, and after that there was a blister and there was a skin cut. I asked my mentor was telling me, when it was very much indurated and there was a blister, that time you have to stop putting processor there. Give antibiotic, let them heal completely, then put some very thin piece of cloth between your processor and implant. Reduce the strength of the magnet. You have done very good surgery, but because of the tightness of the magnets, because child was very young, the whole skin is burned. So this kind of thing should not happen. Always, every small things, be cautious. Because I have explanted my own patients and I have a pain of that. You yourself becomes very sad when you do it, and your patient's attendant and the whole family go into great trauma. Things will happen, but you have to make yourself extra vigilant to avoid all these things. Consult your senior immediately, send your photographs immediately, so that timely action should be done. You cannot wait and watch that I have started azithromycin, somebody says I have used manuka honey, somebody says I have used rifampicin. These kind of things will not work. You have to address the problem, face the consequences, result whatever may be.
Dr. Saumitra, you want to add something?
No, I don't want to add. Nothing more to add. So it's step by step, pre, per and post-operative, all these cares needs to be under a mentorship. That's very important. And pre, again, with I'm absolutely with what Ravi has said, that we need to be, the initial surgeons need to be very sure of good outcomes. So selection should be in such a way the patient should expected to give good outcomes. So those should be the patients. Anatomically straightforward, that's also very important. And while doing the surgery, mentor should be over the neck. So that's there. And post-operatively, even small tidbits that how tight the bandage should be. 24 hours change a bandage to see actually the wound, how it is behaving, what needs to be seen over the wound, and then when the patient should come. And also these are the small tidbits which they have already discussed about.
I'd like to
please.
just add a couple of more points. I would like to say how I trained myself for the cochlear implant. So that would be a better way to say. So, like in armed forces, we have to appear for exam. Once we are selected, then I get roughly around 6 months to 1 year before I join an institute. So, I would say that first we should, one who is interested in going for CI should first have some years of experience in otology. And initially, I used to focus on doing a wide cortical mastectomy, so that I know I can expose the cortical mastoid wide enough. Inferiorly the mastoid, posteriorly the sigmoid sinus, superiorly the tegment. Look for the incus. And in all cases which I had planned for doing canal down mastoid, I started doing a posterior tympanotomy first, followed by a canal down mastoid. That was my way of learning, teaching myself to do posterior tympanotomy. And of course, lot of cadaveric dissection and the surgical steps are already discussed.
We are running short of time, so we'll move a little faster.
Are we? I said, are we?
This is one article I found in net. These are techniques mentioned. So that's for theoretical purpose. I am living. This is one case, special situation. This case I operated on 23rd of last month. Multiple deformity, hand deformity with only 4 fingers, microtia, almost non-existent canal, acoustic meatus. Then actually scans are with patient, so actually I was informed very late, so I could not get much from this. What was there in this scan? Right cochlear nerve was not there. Left-sided absence semicircular canals, hypoplastics. Cochlear duct length is only 21 millimeter both sides. Facial nerve in the right side was not visible according to the scan. Then this is the situation. After starting of the posterior tympanotomy, I found this tissue. I am fast forwarding it. See, I aspirated it. Few drops of clear fluid came. Probably. So, I could not further move for posterior tympanotomy. Then I decided to break the posterior canal wall. I broke the wall. Somehow I found the this malleolar incudal joint. I am again moving it fast. So this is the anatomy. Incus was malformed, only short segment of long process was visible. Short process was not there. There was a band, fibrous band attaching to the bony projection, probable site of stapes. I tried to move it. If it is stapes, it was not movable. Then there was no round window visible. So I again moved downward, drilled canal wall, and somehow I found the round window.
I think this is orofaciodigital syndrome.
Yes.
It has been reported in literature.
Then this is third video. Usually I do one notch, I make a notch, but in this case I made a tunnel because I thought I won't be able to make a overhang. This is round window niche. So this round window is opened and then implant is inserted. It was confirmed with C-arm, and I took a cartilage to repair the posterior canal wall and packed it. First I thought to do cul-de-sac, but I decided against it. So what's your take, sir? You have done almost 3,500 cases. This is my first case.
If you go back to your scan,
Yeah.
go back to the scan.
Yes, sir.
Yeah, look at that, look at that.
Round window is there.
You've got the basal turn on both sides. The round window is there, the basal turn is
But
there.
these sides are facial nerve as per scan, and I could not find the. I
Not-
discussed with my radiologist. They were also saying that facial nerve is not clearly delineated.
True,
So I decided to go to left side. Right side facial nerve was not delineated. Left side it was there, but left side semicircular canals were not there.
No, true. So the fact remains that here, with this particular picture that you've put up, the basal turn is there, plus more. I mean, there is no common cavity at the apex, so you've got the basal turn, you've got more than the basal turn. So you've got a reasonably normal cochlea, and therefore the insertion of the implant would not be a problem.
Yes.
Now, when you say the hypoplastic nerve, then the question is how well will this patient do
It was in right
eventually?
side. Hypoplastic nerve was in the right side.
This side normal nerve?
Left side was normal.
Then in that case should be all right.
Yes.
So did you get the measurements?
CDL was 21. I ordered F19 from Medel.
That's fine. No, I don't need the leg. We're talking about the neural response.
NRT was excellent, sir.
Then the child is going to do well.
I should have put that picture also. It is beautiful.
There's one thing I want to just point out for any juniors who've been watching that. See, in this kind of situation, you have a region where you think where is the foot plate is, and you are finding it difficult to locate the round window round window. Just remember that the round window is expected to be 2 foot plate widths below the lower edge of the oval window. Correct me if I'm wrong. So that's where you should start looking. Okay, so 2 foot plate width below the lower edge of the oval window. That's where you will expect your round window to be.
And one more thing, Dr. Verma, if you go back to that scan, again the top left-hand corner, that one which we saw first, that the round window opening is there, it's not ossified, and the basal turn is there.
Yes.
And this is what I was talking about in the axial cut. When you are looking from outside through the microscope and there is the jugular bulb, it is not coming in the way. That's one important thing which you need to see.
Yes.
In that slide. In that slide. Top left, yeah.
In this particular case,
No, I'm just talking.
the patient had facial paralysis grade 3, so we started steroid, and yesterday I talked to him. He is improving. Eye closure is almost complete, and it's improving. So I think it is some heat trauma or something that.
These patients who have facial nerve paralysis after cochlear implantation,
Yes.
I've had a few. The problem is they don't, you know the nerve is intact, you know you haven't damaged the nerve, but the nerve was exposed and maybe your drill touched the nerve. These children don't improve quickly. They improve, but they take 6 weeks, 8 weeks of tension for you, tension and problem for the parents. So remember, post-op facial nerve weakness after cochlear implantation improves after a long time.
This paralysis was delayed. I think it started on 3rd day, post-op day 3.
I'm talking about immediate.
Yeah. It was not immediate, sir.
Then it's okay. That will get better.
Yes. And it is getting back. That is good part. Picture of the same thing. Then other special situations, sir. Otitis media and cholesteatoma. Dr. Goyal, please. Your take.
Just
How to go for this type of cases?
I think part of it has already been discussed.
Subtotal petoscopy is a choice in this
If
case.
customized.
Yeah. Single-sided deafness. Will you go for it?
In our institute, it is not allowed.
Sir, you are in private institute?
No.
No.
For the first point, otitis media, central perforation, even if it's discharging, one stage, close the perforation, do the implantation. I don't stage it. Cholesteatoma, I would do a blind sac closure, wait for 6 months, and then do it ideally, although I've done it at the same stage also. Single-sided deafness, I don't push the patient for implantation. I don't have any patients, although I've had a few enquiries. In general, no. But one famous example, the girl from Afghanistan, Malala Yousafzai.
Yes.
Yeah, so she had it, single-sided deafness. She had the implantation done almost immediately after the trauma. So she's one famous example. Bilateral implants, if the patient can afford it, of course, bilateral simultaneous. If not simultaneous, sequential. But sequential, remember, you need to train the other ear, so it takes that much extra time. So ideally, bilateral simultaneous.
Yes. Sir, I will leave post-op management, complications, and I will go funding already discussed, partly discussed. The final is what future holds. This is the last question.
Hair cells.
Ticky. Totally implantable cochlear implant, because still we have to have the external part with the implant, and which takes a lot of maintenance, and cochlear people are also working on this, and I think they have got 10 years battery up till now, but I think they are searching for lifetime. So in future we are just thinking of that something coming, Ticky will come, then there will not be any visible part of hearing deprivation.
Now I will start from that side. Dr. Saumitra.
Well, I would not talk about future of cochlear implants. Maybe stem cells will help in future.
Okay, but remember, everything is given by the implant company. They want the profit.
Okay.
They give an injection, everything is ordered, who makes the money? So, the implant, like he said, fully implantable.
It was just like the vertigo symposium sponsored by a vertigo drug, which said that no drugs are needed for vertigo.
It's like that, yes.
So I would say there had to be a short-term goal and a long-term goal. So short-term would be something like a TK, totally implantable cochlear implantation. Long-term goals could be anything from optogenetics, genetic engineering, cell growth, and even there are studies which are working on nerve inhibitory molecules, which are proteins which are present in the body, which inhibits the nerve regeneration after first couple of years of life. So they have worked on other animals where they have shown that if we block that inhibitory molecule, then the nerve regeneration can start, maybe something like that.
Dr. Arindam.
Definitely this
Verma, I think they are giving us indications. They are starting explosions. So the next threat is to our lives. I think we need to wind up now.
Definitely, the size of the implant is getting smaller and smaller. So one day it will be very small. And the one more thing, that now the sound energy has been transformed into electrical energy to stimulate the cochlea. So maybe the other than electrical stimulation, so whatever. So any other thing that can stimulate the nerves. So that will be, and every time I think this much, this intracochlear electrode insertion, one movie come into my mind. There is the Avatar. So if you've seen the Avatar, there is a neural integration. So neural integration. It's no, the English wala. There is a 3D Avatar, whatever. So there is a neuro integration. So inner side into the modulus, the nerve endings and the cochlear electrode that can be integrated in somehow. Then we could not be able to count the electrodes in the 12, 22 like this. Yes. So how many nerve endings, how many electrodes? This will be the integration, and that may be the future of.
So there is research going on that.
Yes, there is a neurotropic drugs and neuro integration.
From mechanical aspect, two things are coming up. Definitely what Dr. Dubey has said, the TK, total implant, it's a single unit processor. Not the processor, even the whole thing which goes under the skin and in the middle ear. And also there is something EAS that where electroacoustic. So it's again helpful. It's again mechanically. These are new things, advanced. So it's again helping who are in the borderline of hearing aid and the cochlear implant. So both the things together integrated. So these are the things apart from genetics and all.
And the most important thing is it should be more economical.
Yes, that is the point.
It should be accessible to all of us.
I'm about to speak that in our country, in our perspective, it should be much affordable.
Yes.
So that a large amount of people can afford it, and so that it can be a surgery which is like a mastectomy surgery.
Company driven.
Surgery should not be like mastectomy surgery. I think.
I mean, by telling
this is-
mastectomy, it's a
Yes,
regular.
this is a very
regular
popular
venture.
surgery nowadays. But in mastectomy and in the cochlear implantation, this is a very tricky surgery. Maybe comes here. This is a very special surgery.
No, I agree. But what I think, a person who can meticulously perform a mastectomy, because in mastectomy, in ideally canal wall down, you need to exenterate all cells from the all deep recesses and
Yes,
areas. So a person who can able to do a good mastoid should able to do implant. That's
Every
what
surgeon can do this
Yes,
surgery.
yes.
This is not the issue.
No, he's probably talking about the expectations.
Yes,
and the,
yes,
You know,
yes.
that aspect. You are
So,
talking about the
surgical expectation. No,
expertise.
every surgeon can do. That is.
So thank you very much, the panelists,
I think you shut up or we have
the
to-
moderator, for throwing light on a very pertinent topic. Now it's the time for the felicitations. I would like to ask Professor Dr. Subhrata Mukherjee sir, who was previously head of the Department of Medical College, presently head of the Department of HIMP, na sir? Bojwaj Medical College. Bojwaj Medical College. So sir, please come on the stage to felicitate our panelist. So first to Dr. Saumitra Kumar, is a very humorous person who can take any topic and say the practical things in a very humorous way. ছবি তোলার লোক আছে, ছবি তোলা, ওকে জেআইএমটি সৌমিত্র স্যার জান, সৌমিত্র দাকে নাম দেখে সৌমিত্র ডক্টর সৌমিত্র কুমার, then to Dr. Arindam, then to Monojendra sir, then to Dr. N.B.K. Mohan, then to Lieutenant Colonel Sunil Goyal, to Dubey sir, then we are running short of mementos sir, so chairperson memento for Ramalingam sir, our own Ramalingam sir, for the photograph sir, please accept it. And for the moderator, we have no mementos. We have just heartful thank and our love only. Sir, please have a group photo. Sir, have a group photo. Group photo. We have it. We have it. আমি সবাইকে বললাম তো, সবাইকে মিস যায়নি তো কেউ। Thank you so much for a brilliant piece of discussion. Here we conclude the day 2.